pachychoroid retinopathy, pachychoroid neovascularization, which is a type 1 neovascularization, and polypoidal choroidal vasculopathy. And this concept of pachychoroid was actually first conceived and described by Bailey Freund, a good friend and mentor who I was very privileged to be able to train under. And he's one of the most brilliant minds in the retina field, and privileged to be able to share his work on pachychoroid with you. So the term pachychoroid actually describes a set of choroidal characteristics, which could be focal or diffuse choroidal thickening, as you can see here, and choroidal hyperpermeability on ICG, as well as dilated choroidal vessels, which can be seen on enhanced step imaging. You can see all the dilated vessels here, which we call pachy vessels as well. So first I'll talk a bit about central serous choroidal retinopathy because it's something that's familiar to all of us. First we have to give credit to Dr. Rick Spade, who first described enhanced step imaging OCT in CSC. And it gave us the ability to image choroid with EDI OCT, and also to recognize that patients with CSC have very thick choroids. So you see the figure on the top left, that's a normal eye here. And comparing with that, patients with a CSC have very, very thick choroids. Okay, this slide is just to show you that central serous choroidopathy can present in a multitude of ways, starting from a young age to an older age, depending on whether it's acute or chronic. As you can see, the top left, you have the classic acute CSC with the stack on the FA. And you also can have acute CSC with fibrin. You can also have chronic diffuse CSC here, as well as with vitaliform, and you know you can have choroidal neovascularization with chronic CSC as well. But what they all have in common is that they have a pachychoroid and a very thick choroid, where you can see there's dilated choroidal vessels and thickness of the choroid. So in CSC, sometimes the ultra-wide field autofluorescence can be helpful in a diagnosis. For example, in this case, we may be quick to say that this is a AMD. However, if you do the ultra-wide field autofluorescence, you can see an area of a gravitational tract, and this will help you change the diagnosis of CSC. Sorry, it's just a bit slow. It seems to have paused. Okay. So this slide is just to show you the spectrum of autofluorescence patterns in CSC. It can be posterior or peripheral, and it can be a hyper-autofluorescence, hypo-autofluorescence, or a mixed autofluorescence pattern. I think it's just running too slowly. When you look at the gravitational tract, sometimes it can be vertical descending or it can be arched to one side. And may I ask if anybody in the audience knows why it would be arched to one side? I mean, we don't really know, but can anybody hazard a guess?
Sleepy pattern.
Yeah, exactly. So we don't know for sure, but we do think that sometimes when you ask your patients, do they sleep on the right or the left side, you correlate with the direction of the arch. So can you see at these color fundus photos, and clinically, sometimes it may be difficult to see where the areas of activity is, but when you do the autofluorescence, you can see very clearly the hyper-autofluorescence patterns, which would correlate with areas of subretinal fluid. You can see that. And hinge. And over here, subretinal fluid. So this hyper-autofluorescence in areas with subretinal fluid, we know is described as an accumulation of unphagocytosed outer segments. But we also find that this hyper-autofluorescence will persist in better resolution of the subretinal fluid. And why is that? Does anybody want to know? Okay. So the reason for that is because of an increased fundus autofluorescence related to outer retinal disruption, which can be explained by reduced photopigment density and the unmasking of the normal background autofluorescence of the RPE, which is similar to the photopigment bleaching effect. So you see here this area of hyper-autofluorescence, and you have an area here which shows up as outer retinal thinning, and that's where you get the autofluorescence. And similar to the photopigment bleaching effect that's mentioned. So you can correlate the autofluorescence patterns with the OCT. Obviously, you get iso autofluorescence in the zones of normal retina and RPE. You get hyper-autofluorescence or mixed in the zones where there's outer retinal thinning and receptor loss, but intact RPE. So you get that hyper-autofluorescence here. And in areas where there is photoreceptor loss and RPE atrophy, you get the hypo-autofluorescence. I was just waiting for the slide to move on. Okay, and then we can do ICG as well as ultra-wide field ICG for these patients with CSC, and you can notice that you will find the areas of leakage to be localized over dilated choroidal vessels. And most of the time you can see the dilated choroidal vessels lead back to congested vortex veins. And in the late phase, you can see choroidal hyperpermeability. So in the mid phase, you see dilated choroidal vessels, and in the late phase, you see choroidal hyperpermeability. You can also do on-fast OCT for CSC. For example, in this patient with acute CSC and some fibrin, when you do the OCT over it, you will notice the area of the whitening, which is the on-fast, which is the fibrin, and in the middle of the fibrin you see an area of lucency, and that usually corresponds to the active leakage of the CSC. And on fast OCT it will show up as like a key lock. Okay, and then you can do OCT angiography of CSC, and those without neovascularization, you will see no network is evident, but if you displace the segmentation posteriorly, you can start to see the pachy vessels appear. Okay, so now we move on to what is pachychoroid pigment epithelial. This all began when we were noticing some patients with good vision, and they have RPE changes. They can be pigmented, they can be hypopigmented in the central macula. There's lack of any obvious drusen in this patient. So what would you call this? Is it early AMD, perhaps? Or maybe it's a pig punctate inner choroidopathy, or a unilateral pattern dystrophy, or pigment epithelitis. And you notice in the fellow eye, it's unremarkable. There are no changes in the fellow eye. When you do the fundus autofluorescence, the RPE changes shows up much more evidently. You can see in the right eye here. And this pattern looks pretty similar to a pattern dystrophy, but you know it's very rare to get a unilateral pattern dystrophy. And if you look more closely at the fundus, you will notice that there's an area of a lack of fundus tessellation, which seems to indicate that the choroid is thick at the area, because you know you see fundus tessellations when the choroid is very thick. When you do the OCT or EVI OCT through the area, you'll notice the RP changes overlying the area of the thick choroid and very dilated veins. And when you do ICG, you will see choroidal hyperpermeability. So what do you call this case with a thick choroid and RP alterations overlying the area of the thick choroid and the vein vessels, but without any evidence of any subretinal fluid at the present stage, or any evidence of previous subretinal fluid, and you also get choroidal hyperpermeability on ICG. without CSC maybe. That means a CSC without the subretinal fluid. So this was discussed in the retina community, and they thought that the word occult was not suitable because occult meant obscure or hidden from view, and this was not the case because there is no subretinal fluid. So they thought it more likely that this would be a form thrust of a central serous actually. So they thought to call it a different name, and that's how pachychoroid pigment epitheliopathy came about, because the prefix pachy means thick, and this was a pigment epitheliopathy. So Bayfreund published this paper in 2013 and described patients with these RP changes overlying thick choroid and dilated choroidal veins and vessels, but with no evidence of any subretinal fluid or CSC. So why do dilated choroidal vessels cause these RP changes, you ask? Let's have a look at a few cases. Like this case, a 6-year-old male with cataract intrusion, but that's not what I want you to focus at. I want you to focus at the dilated choroidal vessels everywhere. Okay. And you notice that overlying the dilated choroidal vessels, there are RP changes which are most evident on the fundus autofluorescence as well as the near-infrared reflectors. And you'll see through the OCT that there's a large choroidal vessel with the overlying RP changes. And even in 2005, this Japanese group with Ono Matsui actually already published this paper showing RP atrophy overlying dilated choroidal artery in a patient with high myopia. See, this is the picture of the dilated choroidal vessel. The fluorescent angiogram. And at that time, there were no RP changes. You can see on the autofluorescence and on the FA, there are no RP changes. But 10 years later, you start seeing the RP changes overlying the dilated choroidal vessel. And this is another video that I wanted to show you. This video was taken by Giovanni, and it shows how the retina is shifting due to the pulsating choroidal vessel. So you can imagine with many years of such mechanical stress on the RPE, it might be plausible that that would bring about RP changes and atrophy. So pachychoroid pigment epitheliopathy may be an accidental finding. Sometimes you just notice patients with non-specific RP changes. And it can also occur in patients in fellow eyes of the central serous choroidopathy, and you find that they have dilated vessels and very thick choroids underneath the area of the RP changes. And most of the time they have very good vision, and they are most of the time asymptomatic. So you do fundus autofluorescence to look for the changes in the RPE, as well as do an EDI OCT to look for the thickened choroid. This is another example of a patient who is young with good vision, with some non-specific RP changes, as well as like a small little pigment epithelial detachment at the back. And you can find that there's a very thickened choroid. Another example of a male with good vision, you also see only changes in one eye. It looks a little bit like just RP changes, but it's not drusen because you don't see it in the other eye. And when you do the OCT A over it, first you can see from the on-fast OCT that there is the area of abnormality is here, which corresponds to this area on the OCT. Of course, there's no networks that you can see, but perhaps you see some distortion in the chorocapillaries. Could be a masking effect, as previously we discussed already. And this is another patient you see with the RP changes evident on the near-infrared reflectance. And on ICG, you can see there is some areas of hyperpermeability. And over the underlying the RP changes are very thick choroid with dilated edge vessels. And when you do the OCTA So this is another 50-year-old female with the same RP changes you see most evident on mothers autofluorescence. You see on the EDI OCT the thickened vessels and thickened choroid. And you see this small RPE elevation. Is this early type 1 neovascularization or the double layer sign that was first described by CT? So I think we all know what is type 1 neovascularization again, but just in case we don't. Type 1 being the sub-RPE, type 2 being subretinal, and type 3 being RAP. So again, type 1 is sub-RPE neovascularization, type 2 is above the RPE, and type 3 is RAP. So what do we call this? Where the patient has, again, minimal evidence of fundus tessellation and minimal evidence of NAR-ANT. When we do the FA, we see a type 1 neovascularization, and on ECG we see a hyperpermeability as well as the plaque center. And the EDI OCT shows again type 1 CNV with very thickened choroid, dilated choroidal vessels. So this type 1 neovascularization is what we call a pachychoroid neovascularization. In the fellow eye, you see there is minimal evidence of any changes except maybe a small RP change over here corresponding to this small RP change here. And there is a choroidal thickness and dilated choroidal vessels. With the ICG, there is choroidal hyperpermeability in this eye as well. So this fellow eye, we follow up starting from baseline. You don't see much changes except for minimal RP changes over here. 12 months later, still about the same. 14 months later, you start seeing evidence of the type 1 neovascularization over here with some subretinal fluid. And by 17 months, you can see it's a full-blown type 1 neovascularization with subretinal fluid. And this patient was treated with aflibercept. So this is what we call pachychoroid neovasculopathy, in which patients had developed a type 1 neovascularization, overlying areas of choroidal thickening, in the absence of any characteristic AMD or other degenerative changes. So this, I have a few cases of pachychoroid neovasculopathy. This is a 63-year-old female with an area of subretinal fluid in the right eye, as well as some changes in the left eye. You have a look at the choroid. There's a choroidal thickening with large pachy vessels and subretinal fluid, and you can see the type 1 neovascular membrane here. In the left eye, it looks like an early type 1 neovascularization, but no subretinal fluid at the moment. When you do the FA of the right eye, you see there is hyperfluorescence, which increases intensity in the late phase to show a poorly defined late leakage consistent with a type 1 neovascularization. And you see on the ICG there is choroidal hyperpermeability. When you do an OCT A through the PED, you can see the tangled network of the type 1 CNV, which corresponds to this area. And how about the left eye? In the left eye, there was an area of hyperfluorescence, which is more like a transmission defect because there is no increase in intensity in the phase. And there is also choroidal hyperpermeability here. When you do an OCT A through the choroid capillaries, you can see the type 1 CNV loop, and if you displace the segmentation anteriorly slightly, it isolates the loop more, but obviously the size is different. So you can see that this corresponds to this type 1 neovascularization here already. So the question is whether to treat, but obviously in this case from the FA we were able to see that there is no leakage at the moment, so this is probably starting of a type 1 neovascularization, but we may not treat, we may just watch it at the moment because there's no subretinal fluid to treat and it's not leaking. So this is an 86-year-old male with pachychoroid neovasculopathy. You can see the RP changes here, and you can do an on-fast OCT to see that the pachy vessels actually come towards the subfoveal area, which is where you can see the area of the type 1 neovascularization. And on OCT A, you see the tangled network. So sometimes you may say, oh, but this patient's choroidal thickness is not that high. So it's important to recognize that you have to see the caliber of the vessels as well, and not just the absolute thickness of the choroid, because if the vessels are very dilated, as in this case, they can still qualify as a pachychoroid. This is this other eye, where you can see again the pachy vessels extend all the way to the subfoveal region on the on-fast OCT. And in this case, you can see again a sort of network of the neovascularization, but it's more compact and placoid in this case. So Kip Bailey-Freund, he actually published this paper in 2012 describing that type 1 neovascularization in CSC can masquerade as a neovascular AMD. And in this paper, he described two groups of patients. One group presenting with type 1 CNV at diagnosis and later was found to have findings consistent with CSC. And another group of patients with a known history of CSC on follow-up developing type 1 CNV. And one of the examples of this is this case, a 53-year-old male with an obvious acute CSC episode in this eye. When you follow him up for a year later, you can see how the neovascularization has developed, and he develops a vascularized PED due to his chronic CSC. So what is the CSC, pachychoroid pneumopathy, pachy-neo, and polypoidal connection? Some eyes with pachychoroid neovasculopathy can develop PCV. If you look at this patient, nothing remarkable on the right eye. But if you look very closely, just an area of localized choroidal and lack of fundus tessellation. This patient is actually a myope with a focal area of dilated choroidal vessels. Here, you can see how very dilated it is. And overlying it, here there is a type 1 CNV, which with time develops into a polypoidal lesion here in the OCT. When you do the FA, you see the hyperfluorescence leakage, as well as on ICG, you can see the area of the polyp. So if you follow this patient up with time, you can see there is actually progression of the polyps. At 8 months, it gets bigger, and 16 months, and 20 months. You can see how the polypoidal actually develops. So this is a patient with a history of chronic CSC with diffuse RP alterations in one eye and a gravitating detachment below in the left eye, which is more obvious on the fundus autofluorescence. You can see the changes are very severe. So 3.5 years after the last CSC recurrence, this patient had a hemorrhage in the right eye. And of course, when you do the ICG, you can see the area of the polyp there and choroidal hyperpermeability here, corresponding to on OCT this polypoidal light lesion. And underneath that, you can see the thick choroid and the large choroidal vessels. This is another patient which on near-infrared reflectance, you can see the changes with the subfoveal region, as well as we can make out a small little polyp here. And this line corresponds to the OCT here. You can see the large pachy vessels in all the cuts. And in this line, you can see this lesion, which looks like a polypoidal lesion. With the ICG, you can make out a branching network over here with this area of the polypoidal lesions. And when you do the OCT A, you can see the tangled network of the polypoidal lesion, but as usual, there is a polyp here that shows no flow signal. This is another patient with pachychoroid and PCV. You can see the area of the polypoidal lesion on the OCT and the dilated pachy vessels below. You can see the polypoidal lesion on ICG, and on OCT A, again, the branching network, which feeds to this area of polyps, which actually have no flow signal. This is another patient with a PCV. At the baseline, when she first presented, she had a massive retinal hemorrhage. And you can see the areas of the polyps clearly on the ICG. When you follow up this patient, of course, she develops subretinal fibrosis after the hemorrhage is cleared years later. But when you do the OCT A, you can still see the area of the polypoidal lesion and the large feeding vessels towards the polypoidal lesion. So this thought that polypoidal is related to choroidal vascular hyperpermeability is not new. So some papers have already shown that choroidal vascular hyperpermeability is a risk factor for polypoidal, and that choroidal thickness in polypoidal vasculopathy is different from that of AMD, and so that sort of already suggests a different pathogenic mechanism in PCV than those in AMD. And this paper found that patients with PCV associated with choroidal vascular hyperpermeability more frequently develop bilateral neovascular membranes, more frequently had a history of CSC, a thickened choroid, and had poorer responses to the intravitreal injections than those without choroidal vascular hyperpermeability. So this is the CSC and type 1 neo and polypoidal connection. Patients with pachychoroid pigment epitheliopathy can go on to pachychoroid neovasculopathy and can later go on to polypoidal neovasculopathy. And this usually happens at a spectrum of age. Like when you're young, you start off with either pachychoroid pigment epitheliopathy or central serous choroidopathy, and they both can lead to type 1 neovascularization, and eventually at a later age can turn out to be polypoidal. So in summary, pachychoroid pigment epitheliopathy may be a form class of CSC. Both pachychoroid pigment epitheliopathy and CSC can develop pachychoroid neovasculopathy, which is a type 1 CNV. And pachychoroid neovasculopathy may develop on to become polypoidal. So PCV should not only be thought of as a primary choroidopathy, but more of a chronic form of type 1 CNV, where it's important to identify the underlying mechanism, be it pachychoroid or AMD. Thank you. So I'd like to acknowledge the PRM in New York, and also Jerry Eye Surgery, from which I got most of the images from. Any questions?
My doubt is when the subretinal fluid is not there, it's a presentation. How did the RPE pump is more effective in popping out choroid thickness is more? Subsequently, when the CNV develops, have you followed up these cases down the line to see whether the choroid reduces at a later date, the RPE pump fails and is it choroid neovascularization?
Yeah, we have done some follow-up of some patients, but normally the choroidal thickness doesn't decrease. It just remains constant. Yeah. But I think it has to be done on a larger scale study to look at that, like post-treatment as well.
Hello, Claudia. It seems that we like to emphasize that most of the pathology of the retina comes from the health of the RPE as well as the choroid nowadays. So are there any supplements right now rather than we wait for the progression of this healthy RPE to become unhealthy? Are there any medication that the patient should be taking prior for this late progression?
I think at the moment, no, I don't know any supplements that we take for RPE health.
So we end up with injection afterwards.
question in your slide that show the pachychoroid vitellopathy in the lady 80 years old. That the slide show is like the BVN on the right side. I think maybe it's look like the PCV but no polyp, but show only the BVN. Instead of diagnosis pachychoroid vitellopathy.
Are you referring to the patient with pachychoroid and PCV?
So before pachychoroid. Yeah, this slide. Because how to differentiate with the patient with the PCV.
Oh, you mean the network? The network looks
network,
like
yes.
a BVN.
BVN,
Yeah, but that's true. The network looks like a type 1 choroidal neovascularization and similar to a BVN. So how you differentiate from a polypoidal is you have to use multimodal imaging by doing the ICG to look for any hotspots or polyps. Also, when you do the OCT, you can actually look for any polypoidal lesions on the OCT as well.
Sometimes we put the dye in ICG, but not show the polyp. Maybe it's gone. Just the one polyp is gone, or the degradation, but show only the BVN.
Yeah, but also on the OCT, if there are polyps, you would see the circular elevation of the RPE or polypoidal loop. But if there's no polypoidal lesion, then you wouldn't see that.
Okay. And another one is the pachychoroid look like the thick RPE.
Yeah, true. It looks like sick RPE, which is similar to that in the CSC, correct? So it is like a spectrum of a progression of a disease. The patient can start off with CSC, perhaps never been discovered, never been seen before, and then subsequently develop pachychoroid neo. So that's what we're trying to say, that the underlying mechanism for the sick RPE is really the thickening of the choroid, the pachychoroid, as well as the choroidal hyperpermeability, which causes the sick RPE. A chicken and an egg, we don't know which one comes first, but it's all a spectrum of the same disease.
Thank you.
Do most of them progress through all the 4 stages, or it's just few of them which progress? Is there any?
Yeah, I think in order to know that, we have to do like a long-term follow-up study, and you also have to be able to catch patients at the peak, the pachychoroid pigment epithelopathy stage, and then follow them up. But most of the time, we don't even identify patients at that stage because they are asymptomatic. You only find them if they're in the fellow eye of the central serous choroid myelopathy in the other eye, or else you find them incidentally when they just come for follow-up check. So you have to do a long-term follow-up study to see all these patients, whether they develop all 4 stages with time. So it's difficult because now we are just seeing patients at different stages.
And is the choroid equally thickened in both the eyes?
Most of the time, so if the patient has a bilateral disease, the choroid is thickened equally in both eyes. But like I've shown before, there are some cases where you can have focal choroidal thickening, and so that the patient develops neovascularization overlying the area of the focal choroidal thickening, so they can have unilateral disease because of that focal choroidal thickening.
Colleen, sorry.
Oh, yeah.
Thank you. Nice paper. Why you call in this case, for example, pachychoroid is only one vessel that looks like enlarged, and not all the choroid of the structure, just one.
Oh, yeah. So the term pachychoroid is used to describe this condition if the neovasculopathy occurs due to the underlying dilated choroidal vessel. So even if it's focal and if it's not diffuse, but it's to indicate the etiology of the neovascularization.
But no, I think it's not the same thing. I mean, if you think all the choroid is thick, like in central serous choroidopathy, I can understand that it's called pachychoroid. If you have only one vessel that is dilated, not thyroid, just one. And it could be that it's only a problem of a vortex veins and that's it.
Exactly, yeah. But initially, the term pachychoroid was used to describe not only diffuse choroidal thickening, but also focal areas of choroidal thickening.
Claudine, I have a question. Do you have any idea, is there any theory as to why some focal vessels may be dilated? That's the first question. And secondly, when you define pachychoroid, is it just based on diameter, or are there other features that you
No.
tell?
Yeah, right now there is no set criteria or set number to what is pachychoroid. It all depends because it's a very fluid thing. For example, a patient who has myopia, you don't expect a myopic patient to have a thick choroid of maybe 300, which in a normal patient could be normal. I mean, someone else. Because in myopia, you expect it to be thin. So if it's relatively thicker for that patient, then you can already assume that is pachychoroid. But that is assuming the patient has a neovascularization or a disease, that's attributable to the thick choroid.
So it's a bit of a judgment factor.
Yes, exactly. Yeah. And the other question about, I think the reason for focal choroidal vessels being dilated, well, nobody really knows. I think it's part of the anatomy, sometimes. And we all know that in myopic patients with very, very thin choroids, they have very dilated choroidal vessels, and that's something that we've been trying to look at to see why. It could be that it's a compensatory mechanism because they have very thin choroids, so they have dilated choroidal vessels to refuse the retina.
Have you had the opportunity to treat any of these patients whom you identified to have an abnormal vasculature, but did not have separate show regression?
If the patient you're saying with a type 1 neovascularization membrane but no subretinal fluid, usually those patients, if the vision is still good, we don't treat those patients.
So what percentage of patients will allow progress to have separate fluid and defect? So if there's significant numbers of asymptomatic body, any of the streams,
Yeah, that's right.
so it's something like this which will get at an early stage, and we know for sure that it's going to progress and eventually drop the vision. Is there a relation between them?
Yeah, I think so. So the key is to really, monitor closely when you see a lesion like that, because treatment is not without risk, so you don't want to have to offer treatment if this is a dormant membrane. Because many patients, actually, we've seen many patients with such membranes, they remain dormant for many years. So it's also a question when you start the treatment, because it can remain dormant for maybe 2-3 years before having the need to start the treatment. So I think it's partly a judgment call, and also you have to follow up the patient to look closely for the development of subretinal fluid. But if you do a fluorescein angiogram and you don't see any leakage, would you feel comfortable to treat them?
So, what kind of recommendation to the young patient who has pachychoroid epitheliopathy not to progress to this PCV or
Well, at the moment, I think for patients with PPE, at least we think of them similar to patients with CSC. It's just that they have not developed CSC yet, but we know that they have they are prone to develop that. So I would think of it in the same way, in that we will encourage them not to use steroids, in the same way that we counsel CSC patients also to come early when they see signs or symptoms of metamorphosis. Also, if you believe in stress-related lifestyle, that as well. Because we did find in the pachychoroid paper, patients with pachychoroid epitheliopathy, they tend to have a more type A personality, stressful lifestyle, and also intake of steroids, just similar to patients with CSC. So you can counsel them in the same way.
So you think that the PCV is related to the lifestyle?
PCV?
PCV, because the PCV is the spectrum, is on the spectrum of
Yeah, it's on the spectrum, but
pachychoroid.
that's why polypoidal is actually, there are many different etiologies for polypoidal. You can think of it as like a chronic form of type 1 neovascularization, because from the histology also we know that there's like it's thin walled and has highline fixation, which are all factors of chronicity. So I think polypoidal is more like a later stage or a variant or a type of type 1 neovascularization. But what the cause of the type 1 neovascularization can be many things. It can be CSC, it can be AMD. So you can get polyps in patients with AMD, but we're thinking that the etiology might be different as compared to those in CSC, and hence it has implications on the treatment response. And also, you can have patients with choroidal nevus who go on to form type 1 CMV, and then in those patients, if it's chronic, it might go on to polypoidal. So it's like a variant of type 1 CMV, and it's more important to find out what the etiology of the type 1 CMV is.
Claudine, do you have any experience with the use of a plenarone in trying to reduce the pachychoroid?
Yeah, so currently in the practice in New York, so we use eplerenone mainly for patients with CSC and who are refractory to other treatments. And we find that with eplerenone, the subretinal fluid does show a decrease. But the studies currently are very small, at least like maybe 50 patients only. And we all know that CSC has its natural history, and the resolution of subretinal fluid might be just a natural history and might not be due to anything that we did. So, but we don't use eplerenone for pachychoroid alone. Yeah, it has to be a CSC patient with subretinal fluid.
There have been reports that the choroidal thickness actually comes down, and that is said to be the mechanism of action by plenarone. I've not personally been impressed by this. The subretinal fluid reduces, but the choroid remains the same. So my question is whether or not you are convinced that this might work as a form of prophylactic treatment, particularly in patients without leakage, right? And you know that at some point they are prone to develop neovascularization or polypoidal. So it would be useful if you had an intervention to reduce the choroidal hyperpermeability. The second would be the use of anti-VEGF agents. There have been some reports coming out of aflibercept causing a reduction in choroidal thickness. What are your views on that?
Yeah, so I think because in our practice in New York anyway, with patients with pachychoroid neovasculopathy, we usually treat with aflibercept because they find that aflibercept tends to be more effective than Lucentis. And also, if it's refractory to treatment, they would add with PDT in combination as well. So that seems to be more effective for these patients with pachychoroid as opposed to just AMD.
Claudine, very nice work, Claudine. May I know for the pachineo, when you look at OCT A, are they generally entangled vessels, or you see also branching pattern, or even similar to the normal AMD thalassemia, or you see the pattern being very different?
Yeah, I think in general, what I've noticed is they look like a tangle most of the time. Oh, and another comment about the eplerenone, because even though there was a study about the eplerenone, but I'm not very convinced that it works, because in our practice when we used it, we didn't see a good response in all the patients, and that was a common finding or consensus with all the retinal doctors, that they couldn't replicate what that paper had published at the time about the effect of eplerenone.
Yeah, and it's also not without side effects. Young men in particular, they are very susceptible to plenarone weakness. So they feel very lethargic, they have weakness, they have hyperkalemia, some of them. So it's important not to just prescribe and leave them alone. So you have to do serum potassium and follow them up. I had a patient who was a runner, and he found that after starting plenarone, even at 50 milligram, which is quite a low dose, he couldn't run. So I think it's important to be aware that all these drugs that you use, even if they work, do have sometimes adverse effects. Are there any other questions from the audience? speaker will be Dr. Giovanni Storanghi.